Hi, everybody. Welcome to our session on telehealth. I'm Tony Leys, Kaiser Health News reporter based in Des Moines, covering rural health issues. We're here to talk about the fast expanding use of telehealth, especially during the pandemic, and how it's affected services in Iowa, including rural areas, and where many specialized health services have been scarce. We have a great panel of experts here to talk about it. I think this hour is going to go quick. They've all been involved in telehealth efforts and seen them expand in the last few years. We have Jessica Lovrien, a UnityPoint nurse and executive director of performance excellence. Sue Gehling, a psychiatric nurse practitioner and owner of Classroom Clinic, which provides mental health services to schools via telehealth. Doug Van Daele, who's a University of Iowa Hospital's ENT doctor and administrator who helps oversee their telemedicine efforts. And Jen Amos, CEO of Encounter Telehealth, which provides mental health services via telehealth in nursing homes and other senior living facilities. I'm going to have each of them talk for a few minutes about how they've seen these services expand in the last few years and what they think the outlook is. Before we get to that discussion, we want to thank our sponsor.
Welcome to the Iowa Ideas Conference. I am Kimberly Hunter, Interim CEO and Interim Associate Vice President of the University of Iowa Hospitals and Clinics. The COVID pandemic brought about exceptional challenges, such as worker shortages and healthcare disparities that really have changed the way we view healthcare. However, it has also highlighted opportunities for innovation and improvement. For example, we have seen a move towards telehealth, which helps us provide better access to care for all Iowans. We know that healthcare excellence is achieved through innovation and collaboration. And that is why we are a proud sponsor of this conference, and we are excited to hear your big ideas on how we can come together to improve quality of life and quality of care in Iowa. On behalf of the University of Iowa Healthcare, we hope you enjoy the conversations, make some great new connections, and leave inspired to help us shape the future of healthcare. Thank you.
Well, thank you. We'll get started. Sue, why don't you start us off? Talk a little bit about what your role is in the changes that you've seen the last couple of years and where you think we're going with this.
Okay. So I'm Sue Gehling. I'm a psychiatric nurse practitioner from Carroll here in Western Iowa. And my specialty is in children's mental health. And several years ago, I decided that if I kind of felt like the cavalry's not coming, and if I didn't do something to help my patients here in rural Iowa, then who would? And so I decided that my patients really motivated me to do something. And so we started a school-based telehealth business because we knew that the schools were facing a mental health crisis as well. And so we provide rural school districts access to children's mental health services through the use of telehealth and our related platform. So we bring teletherapy and telepsychiatry services right into the school, which is where the students are, using rural schools as the hub of a community and using the infrastructure that they already have in place, making it easier for families to get there. And so we're really looking at how can we provide telehealth in non-traditional locations, and how can we, particularly for children with mental health issues, how can we look outside of the healthcare sphere and bring in non-healthcare providers into that team model. It's really kind of an integrated model into the schools and bringing non-healthcare providers or people and making them part of the healthcare team for the child. In this case, it's the educators, because school staff are really our frontline mental health workers for children. So that's a unique model of care that we're providing here in Iowa. And I have already forgotten the question, Tony, that you asked.
Oh, how have you seen it change during the pandemic, and what do you think is going to happen now that the pandemic is starting to ease?
I think it'll continue. I think there will definitely be continued use of telehealth. A lot of people, I think, have found it to be very convenient for them. I think we've found that it improves access to care, particularly in rural communities where gaps exist. I think that for, again, the mental health, I'm speaking of just in the mental health particular space, it works very well. And I think it's continuing to evolve, and we'll I think it's staying around.
Jessica, what are you seeing, and what do you expect?
So hi everyone, my name is Jessica Lovrien. I work for UnityPoint Health Waterloo in the Marshalltown regions, and I am Regional Director of Performance Excellence. So part of my responsibilities include nursing informatics in our region, along with virtual care, and I also have medical staff office in my line of sight. So what we've seen, I think the pandemic really pushed us ahead faster to adapt to some of the critical shortages. We utilize some telehospitalist services in our region to help support during the night shifts, just because we're not able to find providers, particularly in Marshalltown. So the telehospitalist concept, specialties, as Sue was mentioning, we utilize psych telehealth services in both settings in Waterloo and Marshalltown. So I think it's really helped, especially in rural Iowa, bring those critically short specialty services to our facilities to really help ultimately it's about the patient. So really to help give our patients that care. We also have had to adapt to the staffing shortages. And one way we have done that recently is by implementing a virtual admission nurse, just to kind of alleviate some of that time, those time-intensive tasks for our nurses with an admission and discharge. And we have implemented a virtual nurse from 9 a.m. to 9 p.m. to kind of help support those functions, do some time saving for nurses. They're doing the head-to-toe assessment in the room, and then our virtual nurse will assist with those admission questions, gathering that background information, doing that patient education. So that's really been a helpful tool for our staff in this time where we're all critically short nurses.
And Doug, what are you seeing?
So thank you. So I'm, as I said, Doug Van Daele. For the University of Iowa Hospitals and Clinics, I oversee kind of all of our ambulatory operations that are not on the main campus. And telehealth was a part of that well before the pandemic. But in the years before the pandemic, we saw somewhere around 2,000 telemedicine visits a year, which is a really small amount, obviously. We tried to use telehealth as one of our mainstays of our COVID response, so that patients who were sick would get a telemedicine visit. They would then get an in-person drive-through testing. Then they would have a telemedicine visit after to talk through their results and then plan for their treatments. And during the height of the pandemic, we saw 185,000 visits. And the vast majority of those were patients who were suffering from some kind of respiratory illness. So we scaled up very quickly. And one of the things that was beneficial is that I think the vendors also scaled up very quickly. But what we learned from that is that you can treat patients very well virtually if you define the right cohort of patients and you define the care pathways very carefully for that cohort of patients. We believe we were very successful with very high patient satisfaction. Now, what has happened since COVID has perhaps cooled down just a little bit. We still see very robust volumes for telehealth. So all of our 1,600 providers have the capability of doing telehealth. That's in 35 specialties. We are still seeing robust volumes. The most robust volumes we're seeing are in psychiatry, much like many of the others on this call have been discussing. That's over a third of our overall volumes, which our volumes are now still over 100 to 125,000 visits a year. Now we have about 1 million ambulatory visits, so that represents a big chunk of those ambulatory visits. And I think this will continue to continue because when we look at our patient satisfaction for telemedicine visits, 93% of those patients are satisfied with their telemedicine visit. That's extraordinarily high patient satisfaction. So again, I think what we'll see is a lot more patients asking for it. And I think if we define the right cohorts and we define the right care pathways, we can be really successful at improving the patient's experience.
And Jen, remind folks what you're doing and what you're seeing in this.
Yeah, sure. Thanks, Tony. So again, we provide psychiatric and mental health care over telehealth to nursing homes and other senior living communities. So very much focused on geriatric psychiatry. You could say we're kind of the bookend to what Sue does. We're on the kind of opposite ends there, the lifespan. And COVID was incredibly interesting to us in that we saw a much greater acceptance as telehealth as a delivery mechanism. As Doug mentioned, the efficacy of mental health care and psychiatry over telehealth is enormous. And in fact, we've even seen patients who prefer to do it over video than to do it in person. So that was quite big for us. And then also really the stigma of mental health in general has gone down also quite a bit. With so many people experience depression or anxiety during the pandemic, it was a very stressful time for all of us. Excuse me. And then in addition to that, we saw celebrities coming out and sharing their stories of mental illness. So really just a greater acceptance of telehealth, a greater acceptance of mental health care. And then on top of that, for us, CMS, the Centers for Medicaid and Medicare, also removed a number of restrictions on Medicare recipients in regards to receiving care over telehealth, where we could really only provide it for individuals in certified locations in rural communities, like hospitals or nursing facilities. Now we can actually provide telehealth for any Medicare recipient. Now, some of that is only part of the health emergency that is still in place. But we really don't anticipate much of that to go away. Congress was already moving towards removing these restrictions through the Connect for Health Act. This is back in early 2020. And it's just a trend we expect to continue to see telehealth improving access to care across the board for all ages and for multiple specialties as well, of course, primary care as well.
So, and first of all, folks in the audience, if you have questions, please enter them in the Whova app.
Excuse me.
So, Jen, specifically with your group of patients, if somebody has dementia or some other condition, or some older folks are just uncomfortable using technology, even if they don't have dementia, how does this work then?
So by partnering with, say, a nursing home, for example, we collaborate very closely with their staff, their nursing staff, as well as their medical director on total patient care for that individual. So if an individual who has advanced dementia is in our care, most likely that's really going to be more provider to provider interaction. So we're going to be working with the medical director, the nursing staff. If the primary care physician is someone different than the medical provider or the medical director, we may be working with that individual. If someone has a fear of communicating over video, then most likely we're not the right fit for them. We aren't going into communities where inpatient psychiatrists, in-person psychiatric visits are possible. We're really going into communities where there is no specialty psychiatric or mental health care and bringing it to them that way. And really, we don't get a lot of that kind of pushback. In fact, most of our patients look at the video meeting one of our providers over video, just like FaceTiming with their grandkids, right? It's someone who's genuinely interested in their well-being coming to visit them.
And does that surprise you? Like, did you think there would be more complication?
What surprises me is that not so much now post-pandemic, but pre-pandemic, for sure, the pushback was from the staff. And I mean, we even had a nurse once who didn't know what a mouse was, right? That is what's really surprising to me. And the pandemic really helps that because the nursing staff had to use telehealth to provide that care for their residents.
And Doug, you talked about finding the right cohort of patients. What's the right cohort of patients, and what group of patients is this not going to work with as well?
Yeah, so that's a great question. It's a constant source of our discussions among our different specialties. So we already talked about the fact that we believe there's a lot of room in behavioral health to be able to do a lot of good work. I would say from my perspective, what I've heard from our providers is that where there's a lot of need for diagnostic testing and a lot of need for discussing results of those diagnostic testing that need a lot of interactions between the providers, that's a space that doesn't work quite so well with telehealth. But if there are wide swaths. So in my own practice, for instance, I've done the vast majority of my patient surgery follow-ups. We have transitioned to doing via telehealth, unless there's some specific reason I have to touch them related to that follow-up. But that's been pretty consistent among a wide variety of our surgeons. So that's a cohort of patients that in many circumstances may be traveling 2 and 3 hours, even longer, to come back to see me. And if they're doing well, I'll just see them via telehealth and make sure that things are going in the right way.
In their home, or do they go to their local clinic?
They would be in their home. Sometimes they're at work. Sometimes they're, in the car. And so they can really do it from any place, given it's through our patient portal, that they can do it from anywhere they like.
We have a question from the audience. Telehealth is an incredible resource for many patients. However, it will take a significant investment in broadband for this to be better utilized. What measures at every level of government are happening now to accomplish this? But how do you feel like, I guess I'll start with you, Doug, that how do you feel like we're doing on expanding broadband so everybody can use this?
Yeah, that's a great question. I do think that is a ripe area for opportunity, because we do have some very significant broadband deserts in our state. And I think that much more could be done from a legislative perspective. I know that our governor and others have high on their list for broadband access. There's some federal programs that should be able to help us. Many of the individuals on this panel may know what more of what's going on from that perspective. But I think that's one of the major hindrances that we have to being able to do video. Now, many of those patients can do audio, so we'll call them instead, but there is substantial benefit for doing video. And I would also say, back to the question around age groups, I certainly felt that there would be people who were in their younger ages would be more interested, and those who are a bit older may not be. It is not what we find across any of our specialties. It really ends up being the individual choices, because some younger folks don't like to use it either.
Sure.
So it's really about personal choice.
Sue, are you seeing that the schools are all ready to, you work just in the schools, right?
Correct.
Mhm.
Are they all good to go with what you need technically?
So that's kind of a loaded question, actually. Schools are facing a mental health crisis. So the timing is now, to be able to assist them in some way. Telehealth is one way to do that in terms of bringing the missing mental health services that a local community does not have access to. So bringing that into the school for the students. With that being said, the school culture is completely different than healthcare culture. The systems are different, the language used is different. And so being able to just provide telehealth into a school is not as simple as it sounds. There is some onboarding, there's some legwork, and then there's some education with the staff to make that work well. But we are finding success. And what we're finding is that it's by obviously treating their mental health that was previously either untreated or undiagnosed, that then has an impact on their academic metrics, whether it's disciplinary referrals, attendance, or behavioral outcomes. And so there is definitely, I think, a place for this in collaboration with the schools, but it's a process that requires a lot of education to be able to penetrate that school silo or that education silo.
So who refers patients to you? Is it the school nurse or
No, the families, the
the
parents.
families? Okay.
Yep, no, it's all based on parent permission and parent consent. But
How do they even find out about it though?
well, so the school would make their families aware of it, make students aware of it, or parents aware of it within their district, whether it's through parent newsletters or things like that. You know, it might be locally in their newspaper, or whatever marketing the school district wants to promote is entirely up to them. But if you think of it from like a population health standpoint, you know, we're going in, the schools are already doing a really good job of identifying these kids and stratifying them. They're already identified, majority of them, as high risk. They use the multi-tiered system of support, so they already have a risk score in a sense. It's just that we have to understand they're using different language than we are in the healthcare space. They're calling it something different, but essentially that's what they're already doing. And so they're recognizing that you know, this child needs you know, intensive services and supports above and beyond the educational strategies. But how do we get those mental health services and supports? And often guidance counselors will make referrals on behalf of families or make appointments, but it's not the same as working together as a team and being able to communicate together and closing that communication loop.
And then,
so go ahead.
I'm sorry to interrupt. Does the family's insurance generally pay for that then? And has that been an issue?
So another loaded question, 75 to
That's my
80%,
specialty.
75 to 80% of all the patients that we see are on Medicaid,
Mhm.
because there is, let's face it, there's two economies in Iowa. There's a rural economy and an urban economy, and we're focusing on rural Iowa, rural school districts, and there's a high child poverty rate. So there's a lot of kids who are on Medicaid. And across all the schools that we work with, that percentage is holding true. So 75 to 80% of all kids are on Medicaid. Of course, we bill Medicaid. And then the remaining students would have commercial insurance. And so we bill their commercial insurance. Now, you ask if they pay for it. Yes, Medicaid, you know, we're getting paid, we're getting reimbursed. I mean, it's a clinic visit. It's just, you know, we code it with a different code because it's a telehealth delivered service. With all of that being said, we have found that there's still some mental health parity issues with commercial insurance. The example I can use is with Wellmark. We've had families who've had Wellmark insurance deny the mental health visits, regardless of whether it was administered through telehealth or not. But their health insurance policy was grandfathered in prior to, you know, the ACA. And so what we found when we really looked into this, and we've talked with Senator Grassley's office and with Nick Potabom, his National Health Policy Advisor, and there was a big report nationally through the Department of Labor that was released earlier the beginning of this year, that found that there is still mental health parity within commercial insurance companies, and nobody's really enforcing that or following up on it. So insurance companies will pay for telehealth, but the question you asked is if, you know, in some areas are we getting paid? The areas that we're not getting paid on or in have to do with the commercial insurance companies who are you know, declining or not covering. Their coverage does not include mental health and substance abuse. And believe it or not, there's still policies in Iowa that have that.
Interesting.
The,
but Medicaid in general has been paying you and paying
Medicaid
you
will
without
pay
a problem.
It doesn't cover our expenses, but
Sure,
yes, Medicaid will pay.
They'll pay. Okay. We have another audience question. Is a move toward telehealth driving a consolidation of organizations? For example, are smaller or rural healthcare providers looking to partner with larger organizations to gain access to better medical records, patient portals, telehealth technology? Jessica, I think I'll throw that to you.
Yeah, absolutely. I think we did see that some even prior to the pandemic. We have some rural partners that utilize, you know, our EMR or partner to utilize the EMR. So I think we did see that before, and I think it will only continue to see it increase. One barrier that we see is that we all do utilize different telehealth platforms, which makes it kind of difficult, you know, from a patient standpoint. If you're a patient who, you know, has care at the University of Iowa, has care at another organization, has care at our organization, some of the platforms aren't the same. So that's a barrier. But I think we'll definitely see that continue to increase where people are partnering, or at least from, you know, an IT or platform standpoint, just for ease and reducing burden for the patient.
Do you think it'll help keep some of the smaller hospitals open? We've lost one now. Some other states have lost a bunch more than we have.
I certainly hope so. I think the smaller hospitals, especially in our rural state, they're definitely crucial for people to not have to drive, you know, great distances to receive care. So that would be ideal, to keep care as close to the patient as possible, of course.
And Marshalltown is a good example of that, right? I
Yeah,
mean, Marshalltown
absolutely.
really struggled for a while.
Yes. Yes.
How has this affected that hospital, having these services available?
So I think it's really helped Marshalltown, and you know, it's a great example actually, just because they were in April were able to open a new facility, expanding their South campus, and just, you know, really keeping that care in the community. And that's important to those communities, those smaller communities, to have care that's right there at home for them. So I think it's really helped the community of Marshalltown, and we're really pleased with how well they're doing there.
Is there any concern among Iowa healthcare organizations that this is an avenue for competition to come from outside of Iowa, and they could pick off the most profitable services using telehealth, and leave the locals to pick up everything else? Doug, do you hear any concerns about that?
Yeah, I mean, it's frequently a talking point that we do hear. What I would say from my perspective, and what I hear from patients, is that patients do tend to want to be connected to their care providers in a variety of different ways. And that means both an in-person as well as, you know, virtual component. Someone explained to me at one point in time, you know, you may use, you know, Spotify or Pandora or something else to listen to music, but when you want, you know, an in-person experience, you want that to be able to perhaps be close to home. You know, we have Hampshire, which is a great performing arts facility. So the more that I can be connected to Hampshire, the more that still connects me to my local community. And I think patients still like that. I think it does behoove us to be competitive in a positive way. So my one example, we also, like UnityPoint, host some small critical access hospitals that they also use the same technology we do. We have basically virtual consultations with a bunch of our different specialists. So it is true that, for instance, UPMC Pittsburgh has a infectious disease consultation virtual service. They have a rheumatology virtually consultation service. Mayo certainly is working on a hospital at a home. I would say from my perspective, though, Iowans do tend to have some local loyalty around the work that's being done, and want to have some connection, whether it's to UnityPoint or Mercy or us. They want to have a local connection.
But like, I know on mental health specifically, a lot of employers have employee assistance programs that they contract with. And my impression is a lot of them are national companies that, and they may work very well. I'm not dismissing them, but you may be talking to a therapist in North Carolina and may be great, but.
It is true. I would simply say, you know, not very popular, but, you know, we don't have enough mental health providers in the state of Iowa. I mean, if we have to bring in people from outside the state who are good providers, so we want to make sure they're good providers. But I think the more the merrier in this way. I mean, our organization we just cannot serve all the behavioral health needs that exist in the state of Iowa. So whether that's a local startup, which, you know, I think it's great to have the innovation that we see here from our Iowans. We want more. And if we can't get that, we may need to borrow from other states.
And Jen, you're based in Omaha, right?
Yes, that's right. And so we are providing care for individuals predominantly here in the Midwest. We're also up in New England and over the Pacific Northwest. So states with those very large rural populations. And Sue, I didn't know you were a psych NP, but that's the majority of our network are board certified psychiatric mental health nurse practitioners. And they are not located in Nebraska and Iowa because I have one in Iowa. I simply can't recruit because, like Doug said, there aren't enough mental health providers. In fact, I think in the US as a total, we have less than 50%. And when you look at our rural communities, it's not even a quarter. So we aren't going into communities and taking jobs from mental health providers. We're going to communities that simply do not have mental health care at all available.
Is the fact that you need a state license in every state that you're providing telehealth, does that hamper this industry much? And my understanding is that those regulations are about to get tightened again, right? Like they loosened them up during the pandemic, and I see Doug nodding his head. Is it much of a hindrance to the growth of this industry that you might, as a provider, need multiple state licenses?
Yeah, I do think that generally it is a hindrance. There is a compact that many states participate in that makes it somewhat easier to get a medical license, for instance, across a variety of different states. I think we have a cohort of providers who we have licensed in multiple states because, for instance, genetic counseling is something we do a lot of, and there are certain areas that genetic counselors are not frequently seen in many organizations, and so we provide genetic counseling across a variety of states. So I think there does provide also us some opportunity to take some things that we do really well and extend to some other states. But it is true that licensing can be a challenge.
Does anybody else have any thoughts on that?
I mean, it's kind of like any industry, right? You have to deal with the government, and it's bureaucratic and it's a pain. Doug mentioned the compact, so ND compact. There's an RN compact for nurse practitioners. It exists, but no states are part of it. So I don't know, can we elect more healthcare providers to office to help speed up some of this?
Remind me, I should know this off the top of my head. Is Iowa in any of those compacts?
Yeah.
Okay.
Yeah.
With how many, like roughly how many states? Like if I have an Iowa nursing license or medical license, how many states can I use that in?
Well, it's for a medical license, it doesn't automatically grant you a medical license. You still have to apply, but the bar is lower. So as opposed to doing kind of all the stuff, bureaucratic stuff, you may only have to do 30% of the stuff. And then if you maintain the Iowa license, they give you a break on the other areas. So it's not an automatic.
Okay.
Right.
Is there any serious talk about doing a national license?
There's been discussions for a very long time around a national license for physicians. That has stalled for a very long time. It is linked frequently to some of the issues with the National Board of Medical Examiners and those databases, but I don't think it's going anywhere anytime soon.
What are the criticisms of the idea generally?
Yeah, it's a lot of the same things that you were just describing around competition and around the ability for states to kind of regulate their own population and workforce to be able to maintain that kind of quality as well. So there's a lot of quality arguments that are made by individual states that if you have this kind of diffuse, not state-specific licensing, then you won't watch it as closely, for instance.
And the patient wouldn't know who to complain to.
Correct.
Okay. How do we keep people from getting left behind with this? I think specifically of if I'm in a small town, maybe twice a month, a cardiologist comes in or some other medical specialist, which is not ideal. But if I'm somebody who's never going to be comfortable with telehealth, it's something. I can go see that person then. Will this replace that? Because it's got to be way more efficient for a cardiologist. They can hit way more towns in a day doing this than they could with windshield time.
Yeah, I'm happy to answer that question as well. I do agree we have to make sure that in this process, we still maintain as much in-person kinds of activities as we can. I think that many times we are reacting to what patients want, meaning that there are patients who really want telehealth, but those are, the early adopters or those people who are really excited about doing it, and there's plenty who are not. So, the strategy that we have discussed is that how can we engage the local providers, the local PCPs, the local nurse practitioners and physicians around what I would consider virtual consultations, just with the provider to provider, so that the issues can be discussed. And we do have the capability then, for instance, in some of our sites, of having a virtual visit within their local hospital. And so I think it is going to be challenging to make sure people don't get left behind in this way. And I think Sue was talking before about how the school does end up being a good place because people know where it is. They can get to the school. They can, the transportation is clear. We have to be able to do that for our patients that are in these kind of the cardiology example, but it's going to be hard to be able to do that.
Tony, could I
just
address that question too? I actually live in a small town. My husband farms and we live north of Clarksville, which is a really small town. And I think this is definitely an important conversation just because, any access to specialty care for those in my community requires them to drive at least 20 minutes, if not more. So I think it's important, but I think some of the barriers that we discussed need to be addressed first, like the broadband, the internet access, like just everyone having the platform to be able to do that. And, to take part in those virtual visits is an important conversation. But it would definitely increase access. Sorry.
And do you all have,
okay.
Jessica, let me ask you, do you have people who might not be comfortable doing this at home, but they would be comfortable coming into a clinic and talking to a specialist in the clinic and having somebody in the staff help them with the technological stuff?
Oh yeah, quite possibly. Yeah, I mean, I think that in small communities, there are quite a few options that could be utilized, your local library, like Doug mentioned, schools, things like that, those areas that are locations that are accessible to everyone. So I think it's definitely a possibility. And then, having someone there to help support it would be definitely helpful.
And Jen, were you trying to?
Yeah, I was just going to say, yes, some people might prefer telehealth to in person, but really telehealth is here to overcome barriers and to overcome obstacles. So whether that's geographic obstacles, issues with travel and time. Someone saw Doug from their office, probably because they couldn't get off of work, right? To go and see him. And how wonderful is that they can, maybe step into a conference room and have that consultation. So really, it really is just to improve access to care overall, not to replace in person per se.
And then I'll ask a general question so the payments for this really loosened up during the pandemic, and there's talk that that's going to get tightened back down. How concerned are folks about that that's really going to happen, and what effect could it have? Go ahead and start with you, Jen.
So far, the only thing that we've really seen that has changed is that they've removed certain restrictions and certain requirements, such as we can now provide care for all Medicare recipients, regardless of they're in rural communities or urban or suburban. We can provide care for them in skilled nursing, but also other types of senior communities like independent or assisted. And all of those things were already on the table in Congress before the pandemic hit, with great bipartisan support. So I am not too concerned that those are going to go away. One of the things I am concerned about was that right now there's no requirement for an in-person visit. But CMS has said that they may institute a required first visit in person for anyone, again, not in rural skilled nursing or hospitals. And
What's
for us,
the reasoning?
What's the reasoning?
Yeah.
I guess the concern of fraud.
Well,
I honestly don't know, but the thing is, again, we're providing care for people who really weren't receiving that specialized care to begin with. And I can't sustainably fly my providers who are in Texas, right, to come to Marshalltown. We work in Marshalltown, or Atlantic, or, any of these communities across the state of Iowa where we work, to have that first visit. So there are some concerns that some of these restrictions will be pulled back a little bit. I'm not too concerned about the reimbursement rates because predominantly what we do is Medicare, and those rates fluctuate by pennies, really, from year to year for us.
Doug, what are you hearing on this?
Yeah, so we have a little bit of a unique circumstance because we are a hospital, and our in-person visits, a lot of those are hospital-based visits. And those hospital-based visits have two components, a technical and a professional charge, so a facility charge and a professional charge. And I will say that our CFO and most of our finance folks don't like telehealth very much because there's only a professional fee. There's no technical fee that comes along with it. So apples to apples, like an in-person versus a virtual visit, I get less dollars out of the virtual visit, even though the kind of presumption is that it costs us less to do those visits, right? So it doesn't cost me anything to put a doctor on a video visit, right? I mean, that doesn't cost anything, as opposed to paying for the building and for all of those other things. But I don't think that's true. There are costs that are associated with it. Most of my providers would want to have nurses and MAs and others kind of assisting with that care in a team-based care way, maybe social workers and others. So there's this kind of presumption that it's cheaper to provide telehealth because you don't have the infrastructure that you may have with a building. At least that's the thing that's said.
I mean, it seems logical that it would be in the long run anyway, cheaper, that if you didn't need to build as many clinics and
Sure.
doctors and other providers didn't have a bunch of windshield time.
But we have nurses and social workers and all of those costs that are associated with care. If I'm, for instance, signing a patient up for surgery and I did it virtually, I'm also going to need a nurse to come in and do patient education, teaching about surgery and those kinds of things virtually, which is part of that facility fee.
Sure.
And that's just a lost revenue from that perspective. So I know that's specific to the university because it's a hospital, but it is one of the barriers that we talk about a lot in our with our finance folks and others. And it's parity to some extent, but it's not necessarily as robust as we'd like, and it is a barrier. With commercial payers, it's not quite the same because there's more of a global payment instead of this kind of technical and facility fee in the same way. But again, I do believe that the care that's provided is extraordinarily high, and that we have to be able to really reimburse the time for our providers in a similar fashion. And I hope that it continues in the same way. I'm worried that they'll change, but because there is the thought that it's cheaper, right? I mean, I can do a lot more, but I still need the doc or the nurse practitioner or the nurse. It's not like I can have them in two places at once.
Jessica, what are you hearing on this? Are you hearing much concern that there are going to be cutbacks?
I think just as Jen described, I think it's a concern, especially for some of the specialties that are so short in our rural settings. Like it's, sometimes hard to attract different specialties to rural Iowa with harsh winters. But I think, I would hope that would be considered if that decision were to be made to require an in-person visit or whatever they would require, because I think it would be difficult and would pose additional barriers for patients to receive that care that they so desperately need in some cases.
It was interesting she raised the idea of fraud. I hadn't really thought much about that, but fraudsters are always looking for some way. You know, they pretend to be cops, they pretend to be the IRS. Are they going to pretend, or have they already pretended to be healthcare providers and calling because they want to help you? I don't know. Have you heard of that happening, or is it a concern?
I think there's always concern about fraud, waste, and abuse, you know, in insurance or Medicaid and Medicare. So that's, I think, an overarching presence, you know, just like with any, you know, profession, there's always a few bad apples who are willing to, you know, test the limits to see if they can be caught or not. I don't think there's, you know, a lot of it because we're all struggling, but you know, I can't speak for that, but I do think that that's an overarching fear all the time, is that there are those out there who are going to take advantage of the system, and that they're not being monitored close enough, and that they're just found a loophole and abusing it, or exploiting it to their financial gain.
Sure.
And I do think that's one of the things that Wellmark doesn't cover telephonic visits in the, you know, just two-way telephonic visits. It has to be audio video in the same way other payers may cover it. And that was one of the stated reasons by Wellmark, was that they were concerned about abuse. You know, I think for some patients, being able to do that telephone visit is really a lifeline. You know, the video in some of our places with broadband and other things, it's not possible. I have several patients like that, and their transportation issues are challenging. So being able to get some reimbursement for those telephone check-ins would be beneficial.
And Tony, I will just add on the question that you brought up earlier about, you know, changes, and what do I think about, you know, whether or not once this public health emergency, you know, is over, you know, I just think it's going to be hard to put this back in, you know, to take something away that has been there, you know, for the last couple of years, in a sense, you know, specifically talking about like the in-person visits and some of those other, you know, telehealth flexibilities that have been allowed, because so many of the patients that are, and again, I'm speaking for myself, so many of the patients that we're seeing through telehealth are specifically the ones who are the most vulnerable and underserved and in remote areas that are difficult to reach.
So you think there's patients who wouldn't otherwise have been treated, that these aren't just patients getting care in a different way. These are patients who otherwise wouldn't have gotten care.
Absolutely. Absolutely. Especially, I guess, in my field, for sure, with mental health. Absolutely. Children's mental health. These kids would not be getting treatment if we weren't present. And
is that more than just a lack of providers? Is it more comfortable for some people to do it?
You know, it's multifactorial. I mean, one, yeah, there's lack of providers, so we have an access problem. You know, there's a gap in rural communities, and again, I'm just focused on rural communities. But you know, it's also the community surrounding that. I mean, I mentioned earlier that 75 to 80% of the kids that we see are on Medicaid. Child poverty. You know, there is a lot of financial drain and a lot of financial struggles in rural America. So many of these families are working paycheck to paycheck. They don't have money for transportation, for gas money to drive 2 hours to Des Moines. They don't have reliable transportation. And they're employed by industries that are more tied to the agricultural field. And those particular ag-specific industries often don't have the same parent-friendly or family-friendly policies. So it's not as easy for somebody who works at Smithfield or IBP, you know, to be able to take time off to take their child to a doctor's appointment, because every time they're gone for a doctor's appointment, they have to have a doctor's note or something like that. You know, so I think there's a lot of other policies and issues at play in rural areas that make it, they're barriers. They're just additional barriers that are in place that make it a struggle for some families and people in general to access the care and to get it.
How often, and I'll start with you, but I guess this is a question for all three of you. How often during a telehealth visit does the provider say, oh boy, this is something more serious, we need we need to make an appointment or get you to somebody right away in person, that this is not a telehealth issue anymore? How often does that come up?
Are you asking me?
Yeah.
Just for all of us? Okay. So when we work with the schools, we have emergency procedures in place, so we have kind of all these things outlined with schools, should an emergency develop, or what would be an appropriate or an inappropriate, person to schedule for telehealth. I mean, essentially, if somebody's in a crisis, and having a mental health crisis or something like that, they should be going to the emergency room perhaps instead. All of our appointments are scheduled, but that doesn't mean to say that during the visit, something might not come up where we need to notify DHS, or we realize that the family or the patient is having suicidal thoughts, or something that, becomes a safety issue. But I think it all has to do with, what contacts do you have in place at the site visit, where that patient is. And in my situation, the patient is not in the home, it's actually in the school. So we work with the school staff and we make sure that we have procedures and everybody understands what to do should an emergency develop or a crisis occur. And we have the phone numbers and the addresses of that location. Should we, sitting in a remote spot, have to call, the local authorities, we've got the correct address and phone number and location to provide to. So that's how we do it within the schools anyway.
And if you have to write a script, you just send it into the local Hy-Vee or Walgreens or
Yes,
whatever?
everything's electronic, and
Okay.
all the electronic prescriptions are all electronic for us. So we just.
Doug, how often does it come up? I'm sorry.
No,
Doug,
go
how
ahead.
often does it come up in your practice that you?
Yeah, it's a great question. We because there are some specific billing rules about virtual visits and in-person visits, we actually void the virtual visit if the patient needs an in-person visit within a week. So I can tell you that's less than 5% of our visits. Now, we may direct them to the emergency room, and I might not know about those. But but overall, that rate at which we void is pretty low.
Okay. And Jessica, do you have any insight into how often it happens with your?
I don't have any information as far as the data as how often it happens, but we do have processes in place, just like Sue and Doug described. If it's a person doing a virtual visit in a remote area, we of course have home health that's in the, geographically distributed, or processes where they would follow up in the emergency room. The services that we use telehealth for in the hospital setting, we of course would, have emergency room providers or anyone like that of that nature to provide that backup. So that's a great question. I just don't have the data on, how often that occurs.
And do you have any feeling that the shortage, that you talked a little bit about the staffing shortages and how this is going to help in a smaller hospital, is that easing, or is it going to ease anytime soon, the staffing shortages?
We hope it's going to ease, but
Yeah.
I don't know.
You're not seeing that yet?
About anytime soon. So I think it seems to be improving somewhat, but I think we do still have a lot of shortages in different areas.
Okay.
Doug, I don't know if you may have anything to add there.
A lot of prayers. I mean, those shortages are really challenging. I would echo what everyone else has said. We need more providers across the groups, but I don't see it easing as much quite yet.
Okay. Well, we've got just a couple minutes left. I'll ask each of you, and Doug, might as well start with you. Bottom line, is this going to keep expanding? Are we going to stay where we're at? Is it going to regress now that the crisis is easing up?
Yeah, I think that this is going to be part of our regular routines as providers. It isn't quite yet. Some of us are used to our old ways. Patients are going to force us into new directions, and it's the right thing to do. So I think it's going to expand in a variety of really great ways. And I'm excited for some Iowans to help us with some innovations.
Okay. Jessica, what do you think?
I definitely agree. I think it just has to keep expanding, from a consumer driven standpoint. I think that's what patients are going to want. And I think, like from the access issues that we've all talked about earlier, I think it's a great opportunity. It's a great time. Everybody, is so moving in this direction. So I think we just need to take advantage of it. And like Doug said, I think, anyone that has innovative ideas for healthcare, we're definitely open to hearing them.
And Sue?
Oh, and I agree. I mean, we use we always say, change is inevitable, but survival is optional. And no matter what industry you're in, change is a constant. If you don't change with it, you're going to be left behind. And now this is a perfect example. There were early adopters already. I mean, we were providing school-based telehealth before the pandemic hit. This just, really pours gasoline on it in a sense. Now everybody is much more accepting. Now everybody is, adopting it. But now we got to continue to evolve and continue to think of the next innovation and continue to think of the next way that we can collaborate and basically remove these barriers so that we can reach the families and reach these patients that need the care.
Well, we're just about out of time. I appreciate it. If there's anybody has any other last thoughts, otherwise I think we're right up on it. Pretty
There
much.
is a hand up. I don't know if that's.
Oh. I don't see it.
Oh. I see a hand up, but maybe it's been addressed.
Oh, no. I have just seen, if there's anybody in the audience that has one last question. Otherwise, thank you all for coming, and thank you guys so much for participating. I really appreciate it.
Thank you.
Thank you.
Thank you.